So tonight, I really wanted to talk, a lot about swimmer's shoulder. It seemed kind of appropriate with trials coming and everything. Just, you see a fair amount of swimmers that come through periodically, and oftentimes young athletes, but we get some master's level swimmers and whatnot, and thought it'd be a nice opportunity just to tie in with the fanfare and the timing of the season and whatnot with trials. So hopefully we don't have any kind of AV glitches here, but a little bit of background, to some of you probably not really surprising. And some of this might be a little bit outdated, but one of the more recent studies really quoted with USA Swimming, 300,000 plus members, from all the way from your very young 8-unders on up, and with master swimmers, really 50,000 or more. And some of these, the numbers here from a practice demand standpoint, these may have changed as well, but when we look at the background in terms of the demand on the swimmers, mid-season, really we may be looking at anywhere from 8,000 to 20,000 yards or meters, depending on the pool it's being trained in. Now this was back from 1980. I think, and I kind of look back on my days, end of the year, it's 1991, so we're going to do 91 100s on the 1.5. I mean, I don't know. I would imagine to some degree that's kind of changed a little bit. I think there's probably been a little bit of a shift, and some of the coaches can maybe add to this. But there's been a little bit of a paradigm shift in that regard. That it's not so much just pounding out the yards. Much more technical, much more quality training, which is obviously to the better. But on average, even looking at 2006, they kind of estimated roughly 4,000 strokes per shoulder in a given workout. And again, a lot of these are averages. And then even more recently, in 2010, they found that the elite swimmers, so we're talking some of your junior, senior national qualifiers, open swimmers, trials qualifiers, things like that, more than 13 years old, anywhere from 500,000 to 1 million arm cycles per year. So the demand is obviously pretty extensive. Looking really at the combined age groups, we talk about age group swimmers, senior level, and then national team swimmers. There's roughly a 3 to 80% prevalence of shoulder pain, which is a pretty wide variability, obviously. And this is some older data from '93, but at that time, the prevalence, obviously, as you go up in level, experience level, you're just seeing a greater increase, greater prevalence of shoulder pain all the way. And so prevalence at the time of the study of current shoulder pain versus those that just reported a history at some point of shoulder pain. And then the national team, at some point, 3/4 of them had shoulder pain at some point in their training. So the question is, what's going on with this? Well, let's do a little bit of background here first, just from an anatomy review. It might be a review to some, new information to others. Shoulder is the most mobile joint in the body, which is obviously going to be, from the swimming standpoint, really a strong correlation between a level of performance that these swimmers attain and how much mobility they have. So the thought with that is, some of these swimmers that can streamline a little bit better, so they're going to have, off the wall, instead of kind of your average 180 degrees that we might not average, but kind of, we think of that as the maximal range for the shoulder. A lot of times these swimmers are going to have, potentially 190, 200 degrees, be able to get into a real tight streamlined position, a little quicker off the wall. Similarly, you think about it, from a freestyle standpoint at, hand entry, getting into terminal reach, if they have, again, a little 5-10 degrees more, catch the water a little bit more, they have a little bit more pull through per stroke cycle. But the shoulder, again, ball and socket joint, because of its mobility, you're going to sacrifice stability. So it's inherently unstable, and we often regard it much like a golf ball on a tee. The relationship between the socket and the ball, the surface area contact really isn't that great. And so it relies heavily on both what we consider our active restraints and our passive restraints. Actively, we think of that which we have some voluntary control over, so really just the surrounding musculature. Passively, there are several things that contribute to the stability. The joint capsule itself, which is really reinforced by the ligaments. The labrum, which we'll talk about here in a second, which is really kind of a little fibrocartilaginous ring that helps to kind of line the socket. And then there's a small degree of stability provided by a negative pressure within the joint. The shoulder blade, or the scapula, as we talked about, is really kind of somewhat, you could say, connected to the body through the collarbone to a degree, but really through its muscular attachment. So looking at the back, the trapezius, so your upper, middle, and lower trapezius, what's called your levator scapula, which really runs from kind of this upper, where people oftentimes get a little tender, that little trigger point up top, up into the neck, your rhomboids, which kind of run through the middle region and through here, and then what's called your serratus anterior, which really, from a swimming standpoint, that and one of the rotator cuff muscles in particular, is a cause for a lot of problem for some people. It's the dysfunction of this muscle that ends up creating a lot of issue. And so this actually attaches on the underside of the shoulder blade, kind of on the inside, and then wraps around and then interdigitates with the ribs. And if anybody, kind of as we go, I'd like to keep it pretty informal. If you guys have questions or anything, please don't hesitate to ask, or comments or things to add. Rotator cuff. So, and this is really for a lot of people, kind of the underlying problem. Rotator cuff really is 4 muscles. People oftentimes think of it as just one. It's really 4 muscles. We have the supraspinatus, which is kind of on the top portion of the shoulder blade. Your infraspinatus and your teres minor, they're all on the back of the shoulder blade, back and top portion. And then you have what's called your subscapularis, which is on the underside. We're really looking at the front part of the shoulder blade. We've taken the body away. So the underside of the shoulder blade, and it comes more or less up and through and attaches in front. And so hence we kind of get that cuff idea. 3 in back, 1 in front, and helps to provide dynamic stability and more or less keep the ball centered in the socket as you move it around. Some people will kind of talk about what's called the long head of the biceps, kind of the 5th rotator cuff muscle. This is, as your bicep comes up, it actually diverges. You have a major attachment here, a little bit on the shoulder blade, but then you have a small tendon, relatively speaking, that comes up and kind of wraps around the front, kind of top portion of the ball, and then dives into the joint. Because of its proximity to some of the rotator cuff, oftentimes when you see irritation or damage to, especially that supraspinatus tendon, which is oftentimes the one that's more involved, you can see involvement of that as well. And also with the subscapularis. The subscapularis, as it comes around front and attaches in here, it provides stability to the long head of the biceps. We good so far? Make sense? Just a different viewpoint. I kind of added this photo in to really help appreciate, really bird's eye view looking down. This is that supraspinatus muscle. And so we're looking down on this guy's shoulder. And as it comes in here, the tendon really is coming underneath this bony arch. And really wanted to kind of help appreciate for a lot of these swimmers why they're having some of this trouble. Basically, it comes in through this outlet and then attaches on the ball on the side here. And so you can imagine as the arm's going around revolution after revolution, especially if there gets to be a little bit alteration in mechanics, how that can begin to rub on the undersurface of that. Now, if we're talking about a master swimmer, the other thing that can kind of contribute to that is over time, they end up developing some changes, potentially some bony changes on the underside and develop some spurring and whatnot, which really makes sense. It would just start to encroach on the tendon and cause some tendon damage over time as well. Some additional musculature from a swimming standpoint, in addition to the triceps, probably your most predominant ones that we think about are the lats and your pec major, the large pec muscle, because those are going to be your 2 primary propulsive muscles for the sport. Teres major is a muscle that is on the backside or attaches to the shoulder blade and kind of comes around front. We have our deltoid, biceps, and then what's called your pec minor, which kind of lays underneath the beefy pec muscle, attaches to the ribs and then up on the front part of the shoulder blade. The bursa, and when we talk about, say tendonitis and things like that, we can really tie in some bursitis with it as well. I'm sure everybody's familiar with the term. The bursa is really kind of a fluid-filled sac, and the example that I've always thought works well is, if you take 2 hands and rub them together, there's inherent friction. If you take say a little sandwich baggie and put a few drops of salad oil in it, and then put that between your hands, it glides a lot easier and kind of helps to reduce some of that friction. And so that's, to a degree, we can kind of think about what the bursa does. In the case of the shoulder, there's multiple bursae in the shoulder, but what's called the subacromial bursa, beneath this acromion bone, right overhead, it kind of buffers the top part of your rotator cuff from this overlying acromion bone. And that, as you can imagine, again, you're going around revolution after revolution, whether it's freestyle, butterfly, any of them, and kind of predisposes that to wear and tear. The labrum, we touched on it a little bit earlier. Your labrum, again, is this fibrocartilaginous ring, and it kind of basically lines all the way around the socket, increases the contact area with the ball, and helps provide some degree of static stability. that long head of the biceps tendon that we talked about, as it comes up through this groove and dives into the shoulder joint, it actually attaches it, we think of this as kind of a clock, when 12 o'clock, 1 o'clock, and so on. It actually attaches it more or less kind of that 12 o'clock position. All right, so we're good on that, no questions anatomy-wise. So then, what is swimmer's shoulder? Well, here's the unfortunate part. There's really no one definitive problem that's identified, okay? There is one that's statistically more likely, we'll talk about in a second. It's really, swimmer's shoulder is really kind of it's very a broad diagnosis, kind of a garbage pail term, because it encompasses a lot of potential things. Again, you could have rotator cuff or biceps tendonitis, or what's called, or tendinosis, which we'll talk about a little bit later. Subacromial impingement, where that overlying acromion bone, you can have impingement or kind of a pinching or compression, repetitive compression on the tendon and the bursa. Biceps tendonitis, talked about that. Shoulder laxity versus instability, which we'll go into a little bit more detail. So the looseness of the shoulder versus looseness that's just not controlled. You can have labral tears, and then also some things called internal impingement. You can have involvement of the joint at the end of the collarbone, so on and so forth. But really, we're going to talk about these first several in here tonight. So tendonitis versus tendinosis. Well, everybody's familiar with the term tendonitis, and really this is an acute, reversible process of inflammation in the tendon. You can get it shoulder, knee, wherever, elbow. True tendonitis, you often see it more in a younger population. For myself, you go out, I decide to build a deck over the weekend, I get a little bit flared up, self-limiting problem, my shoulder may hurt for a few days or a week or whatnot, a few weeks maybe, calms down, goes away. Especially since I graduated, in the late 90s, the term tendinosis has become a little bit more prevalent. And what we see now is more of a chronic tendonitis. And the difference being that instead of just being this acute inflammatory process, you'll actually see in some of these people that have this degeneration of the tendon in the absence of a real significant inflammation. Now, we can differentiate between these two, but in reality, clinically, you probably see people that may fall in a spectrum, and Dr. Hutton may be able to add to that or whatnot, but I imagine you probably find more people that they're not necessarily one or the other. You may have people that kind of fall along the course of that. You can have somebody with chronic tendinosis, does something, gets even more flared up, and so they have more of an inflammatory condition. But in both cases, in theory with tendinosis, it's still, unless it's horribly, horribly advanced to the point that now you have some cuff tearing and things like that, then it's potentially reversible. The problem is, whereas we might be talking in terms of weeks and whatnot, we may be talking in terms of months here for some people. And this is important, especially from a master swimmer standpoint, because we're really talking about two different populations of athletes. And with this, as I mentioned, this is currently thought to be, especially based a couple of years ago, the study that came out, to really be the most common cause of shoulder pain in these swimmers. Both of these, not necessarily tendinosis, but really both of these. So if we're talking about your master's level, it may be more of a tendinosis problem, maybe somewhat of a tendinitis. In our younger, more middle school, high school, college, and whatnot, kind of a tendinitis. And a lot of it depends on when do they finally tell you they're having symptoms. When do they finally go in and see somebody for it, an orthopedic physician or whatnot. When do they finally get care? So how quickly can you catch it? Subacromial impingement, we kind of talked about that. Again, this is a compression of the rotator cuff and or that bursa against this overlying kind of bony and ligamentous arch. And so with this repetitive compression, you can get inflammation of the bursa and tendon, and if left unchecked or untreated, can eventually lead to progressive degeneration, and again with the older population, potentially even rotator cuff tearing. The terms laxity and instability. You can have laxity and be completely asymptomatic. I would argue that most, if not all, of your high-level swimmers all have inherent laxity. They would have to be, really, in order to be competitive at the higher level. But really, again, laxity in and of itself isn't a problem. There's some thought that it does relate to shoulder pain in swimmers, but there are a lot of swimmers in the studies that are hypermobile, that they move excessively, that they're asymptomatic. So why are they fine and these other people are symptomatic? It's only when this laxity starts to become painful that we call it instability. And so really the current thinking is that you have somebody who is maybe a little bit looser. Because of that, ball and sockets, or balls moving a little bit more around in the socket. It has, we talked about those two different restraints. We have the active restraints and we have passive restraints. Well, in these people, their passive restraints are a little bit looser. Either over time they've just become looser by the demand of their sport, or just genetically that's kind of how they're put together. So because of this increased movement, or, and I'm not talking a lot, but we may be talking millimeters, but when you're talking about thousands of yards of training, that can start to add up. So the muscle, the rotator cuff, and everything else has to start to work a little bit harder to try to control this. That leads to premature fatigue. Now you start to have instability. Now you start to have pain. Labral tearing, and again, this is something that when we talk about treatment and surgical standpoint, even some of these other things. If you guys have questions, Dr. Hutton can probably field them to a large degree better than I can. But labral tears, really the SLAP tear, as it stands for, superior labrum anterior to posterior. And we see this a lot in a lot of throwing athletes, but you can also extrapolate that to a lot of the swimmers given the overhead nature of the sport. So here, we talk about kind of the clock nature of this labrum. So if we're looking straight in on this socket, we're talking about the upper portion of the labrum front to back, usually somewhere, maybe 10 o'clock to 2 o'clock, thereabouts, 9 to 3, what have you. There are really 4 types that are often described, and it really has to do with the degree of involvement of damage to this labrum. You can have just some fraying of it, which would be considered type 1. There are a lot of people who potentially have that, but again are asymptomatic. You can have type 2, which involves a little bit more, and type 3, type 4. Biomechanically, when we talk about swimmers, you're going to see this a lot more with butterfly, backstroke, and freestyle. You really don't see a lot of breaststrokers in for shoulder pain. They're in for knee pain. And really, other than when they're coming in through here and out in front, where they do get overhead, and potentially as they come in through here, there's not as much of the repetitive overhead problem. Butterflies especially can have some issue with this because that bicep tendon that we talked about that kind of anchors in on that 12 o'clock position, one of the positions that, really the position that puts it on maximal stretch is if we come back, we kind of extend the shoulder, we turn the palm facing backwards and come around in here. Well, you could, obviously with freestyle it's an issue, but with freestyle we can at least have some body roll to alleviate some of the stress. With butterfly, you can't. So you have basically a flat torso, and as you come around, every time they go to finish and they come around in here, they end up more or less putting traction on this. And over time, you can start to have some issues with that. Bankart tears are a little bit different, and I would say more than likely you're not going to see that as much. A lot of times these Bankart tears can be a little bit more traumatic. I had one, dislocated the shoulder, college, playing water polo, wave running, that sort of thing, and ended up having to have surgery. But in this case, what we deal with is, if we think of the clock issue again, now we're looking more at kind of the front to bottom portion of this labrum. So the ball may dislocate, and a lot of your dislocations really occur more down and forward. When it falls out or when it dislocates there, it can kind of tear that labrum and stretch a lot of the ligaments there. And so from a swimming standpoint, again, biomechanically, you're going to see this a little bit more in backstrokers and butterflyers, because as you come around here on butterfly, you're going to be levering that ball a little bit more towards the front, and repetitively, especially if they're loose, that can start to wear on this portion. Backstrokers, it's a little bit more of an issue because as they come in through here and on that initial hand entry and catch, and they come down through, it really starts to lever them even more. Now they're in a little bit of external rotation and then trying to push through. And so I would argue actually that really, if you're going to see this as a result of cumulative trauma, more than likely it's going to come from a backstroker. But like I said, I in my experience yet, I haven't seen a swimmer that's necessarily a Bankart tear. I don't know if Dr. Hutton ever has.
No.
All right, where do they report this pain? So you guys are going to be working with them. It's variable, unfortunately, but more often than not, they'll complain about pain in kind of the front, kind of the top front portion of the shoulder, especially if we think about the tendonitis and bursitis. Very common that they may be all right here, but have a lot of upper arm radiation. And so the shoulder can, theoretically refer pain up into the neck and all the way down the arm, but statistically, I think you'll see it a little bit more kind of into this lateral arm area and often above the elbow. Back in 1977, couple gentlemen kind of described 4 different phases of pain, and these are the ones that coined the term swimmer's shoulder. And they broke it down to swimmers that only have pain after heavy workouts, pain but not disabling, so they're able to continue training during and after heavy workouts, and then progressively getting worse, so pain both during and after workouts that now it's affecting swimmers' performance, and then ultimately shoulder pain that's so bad that it basically prevents them from training and or competing. So why does it happen? When we think about these, well, potentially very multifactorial. For some swimmers, really what we find, and you see this especially in the fall, and really the rapid advancement of training, and this probably applies a lot more for your non-year-round swimmers. Okay, so more you get into your high school, and whatnot. So you have these kids that maybe they played around over the summer, but they didn't really do much. Yeah, they said, yeah, I ran, I was active. That's from that standpoint. But then school starts up, and they say, well, high school's starting here in November. I got to get in shape, so they do a preseason program. They hop in, they have no training base. Who knows what their mechanics look like? And so you kind of combine all these things, and they all lend themselves to just this introduction of potentially a little bit more volume, yardage, and demand on the shoulder than it's ready to handle. The other thing to consider is insufficient recovery time, and I think there's probably and again, coaches might have a little bit better opinion on this. There's probably a little bit better awareness of this now in terms of the training styles, and so here we're dealing with kind of this cumulative micro trauma on the shoulder. So and really the muscles, tendons themselves, but without enough downtime, and that doesn't necessarily mean time out of the water, but just modification of the training yardage, cross training, whatever the case may be. And so the problem is the body, obviously for them to improve, you have to introduce this whole principle of overload, but overload without adequate recovery just can eventually lead to more progressive degeneration, tendon inflammation, that sort of thing. Faulty stroke mechanics. So there's kind of 3 things that I often look for with these swimmers, and really we're looking at freestyle. Butterfly has its own issues, but most of the research out there now really looks at freestyle, because that's where you see from a training standpoint a large amount of the yardage. So when you consider warm-up, it's not necessarily effort sets, but even some of your effort sets, and then obviously cool down. So there's just volume-wise a lot more time spent in freestyle. So we think of these stroke mechanics in 3 different ways. So insufficient long axis rotation, which for the coaches really, and some swimmers probably nothing new, but in order for the shoulder to really be properly positioned in the water, we need to have adequate rotation in through here. So really with that you get this optimal positioning of the rotator cuff biceps tendon. If the arm is out in front and here, you really have, especially that supraspinatus muscle that we talked about in its tendon, is going to be brought around a little bit more to the underside of that overlying kind of ligamentous and bony arch. If we can get him into a little bit more body roll, if you remember back on that picture, normally, assuming there's no big spur or other real anatomical anomalies, there's a little bit of a kind of an apex there. So ideally what we'd like to see is we'd like to see them in that position. When we have people say for a post-op shoulder cuff repair, I'll start them out. If they're working on early resistance or active elevation, I may work them in this kind of diagonal plane to try to really optimize that. So with the swimmers, if we can get them in here and get some adequate body roll, then hopefully they're not in this position of kind of impingement. Cross midline hand entry, and so it's a similar issue. When they come around in here, if they're coming around and crossing midline, one of the positions or one of the problems is that where that top supraspinatus tendon comes and attaches, if you bring them up and then you turn them inward, it just kind of brings that up and around and bangs it into the underside of that overlying arch. And so if they come in through here, they're just kind of smashing into it already. One of the things that you might do clinically is an impingement test is just take them overhead and smash them in purposely to see how symptomatic they are. Add a cross-line position to that, a cross-midline position, and it can add to that even more. Excessive shoulder internal rotation. So by that we mean that thumb down at hand entry. And so as they're coming around, a lot of times they may enter a little bit more rotated. If the hand is turned inwards to the point that their thumb is down, the elbow and the upper arm are ultimately going to follow. And for that same issue, you now get that kind of the outer, or the further portion of that tendon and tendon itself and where it attaches on that bone, kind of getting pushed up and under that overlying arch. And so it contributes to this similar compressive effect. So hopefully this was working, so hopefully it does. So this was a swimmer, just a little bit of background on him. In our SwimX over next door, we'll put some of our swimmers in here. It's kind of, it has the capability, you can turn it on and ramp the current up pretty good. It's been able to handle people so far because from a stroke mechanic standpoint, I'm not having them sprint. I'm having basically say, okay, I want you to swim like, basically you're doing a 200 or 400 pace. And so you get them in here, you can crank this up, and it's kind of the treadmill for the swimmer, kind of like the flume. And so this guy was a high school level swimmer. He didn't have a lot of training background. He had just started swimming a couple years before, and so when I watched him, it was pretty apparent. He's a pretty dramatic example of a couple different things, especially right side. He was bilateral shoulder pain, real excessive cross midline position. As he comes around, he's a little bit more along that thumb side on his hand entry, and then he kind of de-rotates and then starts his pull through. But you can imagine every time he's coming around how tight he gets up in here, and then from that point then he's starting to have to pull through and he gets that repetitive compression. Ideally we'd like to see him maybe enter lateral to the head a little bit, but not necessarily a wide hand entry obviously. And then the same, you could kind of again extrapolate some of these principles to your backstrokers. A lot of these, especially these kids that haven't been trained as much, and they're kind of entering way over in here. They've got the pinky entry first, but they're just, they're turned inward to get that pinky entry, but they're so tight to their head that they're really smashing that. And so those are kind of some of your red flags. All right, so some other things that contribute to it. Weak rotator cuff and scapular muscles. Your shoulder blade muscles in the front part of the cuff. And really, if you recall some of the anatomy review, that subscapularis muscle that is on the underside of the shoulder blade, it comes around in front and attaches to the front part of the arm. And it contributes heavily to your pull through. That, as well as that serratus anterior muscle, the one that's on the underside and comes around and attaches to the ribs. In freestyle, they fire continuously. They never rest, both during pull through and recovery. And so they're obviously highly susceptible to fatigue. And so, and not only that, but really, you have to have, especially on your butterflies, but freestyle as well, you have to have appropriate positioning of that shoulder blade, and really for the rotator cuff to be able to fire appropriately and get the arm position. But on your butterflies, especially as they get going, if they are not able to get out and around, let's say they're on a 200 fly and they're on that last 50, and they're so weak in through the mid-back, they can't quite get their shoulder blades out and around, they're going to get it from somewhere. And so usually, again, these kids are inherently pretty loose, and so they get it from the ball and socket. And so now they're tapping into that laxity, and they're demanding that much more of the ball and socket. Whereas if they were that much stronger into the shoulder blade muscles and had enough endurance to continually get the shoulder blades back and out of the way to allow the arms to come around, they tend to do a lot better. So, and the training with and we'll talk about this a little bit more later, but the training with these athletes, it definitely gets away from your 3 sets of 10. I mean, with some of these swimmers, except for the sprinters, if we're looking at kind of your mid-distance to distance, fairly, low weight or low resistance, and they're just hammering out the repetitions because functionally that's what they need to be able to do. And then this is kind of, the big thing that we've been hearing about, especially in the last decade or so, is a weak core. And by core, people oftentimes just think of abs, and it's really not just abs. We're talking abdominals, low back, down into the hips. And so the ability, and again, thinking freestyle, well, any of them really, all 4 strokes, but especially your butterflies, their ability to really maintain a proper hip and pelvic alignment, really is what's important for the shoulder girdle to be able to position this during the stroke cycle. If they start dragging, obviously, they're going to start to compensate that much more up top and demand that much more on the shoulders. And so that's why when we think of core, it's very much, yes, we do medicine ball work, we do some Swiss ball work and whatnot, but it's definitely more than abdominal work, which is, I think, what a lot of people tend to think of when they think of core. So what do we do for these athletes? Well, for tendinopathy, which is just a term, it's kind of a general term, we're referring to tendinitis, advanced tendinosis, things like that. It really varies depending on the stage of tendon involvement. So if we're talking about a young athlete, we catch it early. Rest, ice, anti-inflammatories. In therapy, we may use some anti-inflammatory modalities, a couple things that are designed to kind of push some anti-inflammatory medications into the skin. It really only works for your more superficial, real shallow tendon problems, which is usually the case in the supraspinatus tendon. And the rest, by that I mean relative rest. I really try not to pull, when I'm working with some of these athletes, I really try not to pull them out of the water for a multitude of reasons. Bare minimum, psychologically, if they can just participate with the team and not have to be out completely sitting on deck or just doing dry land or whatnot, that would be ideal. So I know some of the swimmers that I've had from Tom in the past, they end up spending time doing a fair amount of vertical kicking. Even post-op, if they end up, having surgery or whatnot, once they're far enough out post-op, we can still keep their arm out of the equation, but start getting them back in the water. And during this time period, obviously, if it's early enough, identify any faulty stroke mechanics, strength imbalances. Ideally, we try to cross-train them. Again, it's part of that relative rest. Take some time to maybe do some other things. Vertical kicking, touched on that. With the identification of the faulty stroke mechanics, one of the things I kind of want to mention is that, I remember back when I was swimming, there was always the issue with the dropped elbow. You drop in your elbow with your freestyle. One of the things to consider is that oftentimes that's a sign of problems for these kids, because what's happening on freestyle, as they come around, if they're not telling you they're having problems, one of the things they can do biomechanically to alleviate that is they put themselves in just a little bit more external rotation. They'll drop their elbow down as they come around. And so if you have a kid that maybe isn't real open about some of these things, then that's something to kind of keep in mind. That's not saying all the time. Sometimes they might just be out because they're lazy and whatnot, but that's something to consider. If there's some other red flags or whatnot, or getting out, maybe their performance is really starting to drop, that's something that I think a lot of people don't realize, is that they may be doing it just to avoid the pain. They don't consciously realize it, but they just realize that, hey, that doesn't hurt as much, and so the stroke mechanics change. For tendinopathy, mid to later stages, same as previous. So again, rest, ice, anti-inflammatories, whatnot. Research has shown with some of this kind of tendinosis that strengthening, you can still do icing, you can still do all these things, because there are some other things that happen with that. Even though theoretically it's not as much of an inflammatory process, but they found that from a strengthening standpoint, what helps to help remodel that tendon the most is kind of an eccentric program. And by eccentric, that's that phase, if you're doing a bicep curl and we're bringing our weight up, that's concentric. If we're lowering it down, that's eccentric. So it generates kind of the greatest amount of tension through the muscle tendon unit, because the muscle, as it's contracting, it's lengthening. So inherently, it generates a little bit more tension. Well, they've just found, and this again is applied really across the body, not just the shoulder, but knee, ankle, you name it, elbow for lateral epicondylitis, things like that, that this eccentric training program can really help with getting that tendon to remodel over time. In all these cases, generally I try to tell these athletes, avoid kickboards, because as they're sitting on this and the body's sinking down and the buoyancy of the board is shoving them up, it just kind of jams that rotator cuff tendon up against that underlying bony and ligamentous arch. Sustained streamlined positions, and by that I mean if you have your backstrokers and maybe they're just doing a kicking set, you'd be better off taking them on their asymptomatic side and having them lay on it, or just put the one arm overhead or whatnot, because again, it just, in a sustained streamlined position, you're running into potential issues of impingement, especially if the tendon is already a little swollen versus swollen. Hand paddles, I don't even know, are you guys still using hand paddles a lot for training? Some?
Yeah, a lot for teaching, actually.
Yeah.
Okay. I remember, we did some high volume hand paddle sets, and the problem is, it's not a training fault. There's no issue in doing it. In a symptomatic person, it can be an issue because of this large surface area at a distance from the arm, that you have this long lever arm and this huge resistance down there that these kids are trying to pull on, and it can apply a little bit more stress up top. So during their recovery phase, Usually we try to avoid the hand paddles until they're asymptomatic. The other thing, at this point now, they've gone in, they've seen Dr. Hutton, they may end up, corticosteroid injections, and then ultimately surgery. And surgery, really we're talking about some of your more advanced cases that really are just unresponsive to treatment. In some of your master swimmers, your older population, statistically you get above 40 and you start having fewer incidents of tendinitis and more incidents of kind of tendinosis, and ultimately, as your decades advance, rotator cuff tear. Once they tear, they don't heal, unfortunately, and that's where you may be going in and having surgical consult, ultimately, if it's symptomatic enough. For impingement, from a treatment standpoint, one of the things that really contributes to impingement in these kids, and I'm thinking of the high school and college athletes, is the typical swimmer posture. Thank you. These athletes are very, as I said, very lat and pec dominant. They're extremely strong. Well, pec comes in and attaches around front. Lats come up, down low in your back and wrap around and attach in front. As they get develop and whatnot, it kind of contributes to this internally rotated and kind of protracted posture. And so postural re-education is huge. What we know about impingement, and again, kind of that compression of that cuff tendon, that supraspinatus tendon, and the bursa, if you take somebody and they're sitting in good posture, they have X amount of height of space between that overlying bone and the ligament and the tendon and bursa. If you take them and you immediately just kind of start to drop them forward, allow the shoulder blades to round forward, that decreases their height. And so that's one of the things with impingement. Postural re-ed is huge. So we do that. Anti-inflammatory measures to address the inflammatory process, although unless you do some of these other things, that alone usually, it might take care of it for a while, but then they'll be back to see you. Stretching of the front structures, so this pec major and pec minor. One thing I should have also put on here, so getting them, I'll get them, if they're not really symptomatic, I'll get them up and start some pec stretching in through here, get them to open up a little bit more. Pec minor, again, attaches on these ribs and comes up and attaches on the little bone in front. And so a lot of times you'll find if that is tight, it causes that shoulder blade to want to round and tip forward a little bit. And so some of the things that we see in the swimmers, when you look at them from the back, a lot of times, even just standing there, you can kind of see the bottom little bony prominence sticking out. And so oftentimes that's caused because they're so tight on front, it just literally tips them forward. Problem is you have somebody who has a tight pec minor, how easy do you think it is for them to come around on a recovery phase, especially on butterfly, where again, you can't rotate the body to assist with the arm position. It's all coming from the shoulder blades and whatnot. And the other thing I didn't put here that I mentioned is stretching of your lats. And really the way that I have most of the swimmers do it is, just sitting, elbows on a table, sitting on a stool, keeping the hands vertical, and then just dropping back. And that really just starts to stretch the lats out. And the lats, I think we can all appreciate, especially when I look back at the trials and Olympics from 4 years ago, and we'll see it again. You put a lot of the females in these technical suits, and their lats are just bulging over the side. I mean, they're just huge. So stretching of that would be important as well. Shoulder blade strengthening, so the rhomboids, especially your mid and low trapezius. I don't know that I've ever met a swimmer or any patient for that matter that needs to strengthen their upper trapezius a whole lot. Usually that works just fine. What we lack a lot of times is that middle trapezius and low trapezius, which help in drawing those shoulder blades back and keeping them properly positioned, especially during this recovery phase. And then impingement, you may have a surgical intervention because you can have, in our older population, again, I mentioned that some people can develop a little spur on the underside. Well, the problem is it doesn't go away. And if that spur advances enough, you just lose that much height that sometimes they have to go in and they do what's called a subacromial decompression. And there are some other things that they can do too. But they basically just shave that off. Instead of having the spur with a little hook on it, they shave it off to kind of flatten that out so there's that much more headroom. All right, the issue of instability we kind of touched on. Again, and you'll see this pretty much for almost, really you could apply postural re-ed to probably any swimmer because usually all the posture is terrible. The postural re-education, again, we're talking when you come around forward, everything starts to want to draw forward a little bit, shoulder blades are tipped, And pec and lats want to kind of contribute to this forward positioning, the forward pull of the ball in the socket. And so with the instability, it's a heavy amount of rotator cuff and scapular strengthening. What we're trying to do is improve your shoulder blade muscle's ability to keep the shoulder blade properly positioned. Because remember, the socket and the shoulder blade, it's all one bone. So if the shoulder blade starts to become dysfunctional, the muscles aren't controlling what it's supposed to do during the stroke cycle, it automatically changes the orientation of the socket relative to the ball. So a lot of shoulder blade strengthening, rotator cuff strengthening really goes without saying. Again, we're looking at kind of endurance-based exercises most of the time. Core strengthening, again, really you could extrapolate that also to all of these problems. Again, trying to improve overall body position in the water, because if we start having issues in between here and here, you're not going to be able to maintain proper shoulder blade position in the water either. There's a term called proprioceptive training, which is a fancy term, improving the body's ability to kind of improving the joint position sense. So, and with that, tying that in with their rotator cuff and shoulder blade strengthening. So you may have some swimmers that, with chronic shoulder pain, they really have very poor control in these more extreme ranges. And what we want to do is we want to try, it's one thing to do some rotator cuff exercises down here, but that's not usually where they have problems. They're having problems potentially up in here, early to mid part of the stroke cycle, maybe mid-recovery, they're more opened up. So what we'd like to do is we'd like to train their rotator cuff and their shoulder blade, especially their cuff, to control and try to help keep that ball centered in these extreme ranges. So, there's several different things that you can do therapeutically, but, once they're not symptomatic or as symptomatic and we can get them up in these positions and they're not painful, we start to try to train them a little bit so they gain dynamic control of that ball in the socket. Does that make sense? Okay. Instability. The other thing is that, some of these athletes ultimately do require surgery. You do all the right things, you cross all your T's, dot all your I's, but inherently they are just loose. And no amount of intervention. I mean, you usually try to exhaust these options. And if these don't work and they really give it as good a try as they can, which implies that they have to have a real good compliance, which is a little bit of an issue, especially with some of the younger athletes. You give them some exercises, they go home, and they might do them for a while, but then they fall off the radar. But ultimately, a surgical intervention might be necessary. That could be one of a couple things, but what they're looking to do is basically kind of tighten up the ligaments, tighten up the capsule around the shoulder a little bit, try to add to that passive restraint and improve the stability that way. With the labral tears, initially, if they've been diagnosed with a labral tear, we want to try to make sure that we try to treat them conservatively in some athletes. Remember, there are a lot of people that walk around who have labral tears, they're asymptomatic, and they can function quite well. And so we have to be careful that you treat the individual, not the MRI. And so we may try a conservative approach to them, but eventually, the labral tear, like the cuff tear, doesn't heal on its own, and so they may be surgical candidates as well. And so that involves basically going, you see Dr. Hutton, you go in, and using some special suture anchors, they can kind of tie that back down or anchor it back down. The other thing from a treatment option, really a video analysis. You saw the one example here, and I'll use this with some of the swimmers. Not all of them need it, but some of them, especially that gentleman, and I kind of get a clue with someone during that initial visit with them, what's their training background? You have somebody that comes in, I don't train year round, if it is kind of this, I see them in October, they started having pain 2 weeks ago as they started training. I may throw them in here in the pool, in the Swimex, take a look at them and visualize some of these things. It also helps for these kids and the athletes to really improve what we consider kind of their kinesthetic sense. When I swim in the water, I know I do not feel that I look like what I do when I watch myself on video. I lope a lot. I don't feel like I do it in the water. But when I see it on video, it's clear as day. So it really helps for a lot of the swimmers to be able to see themselves and think, I didn't realize I did that, because they have no sense of it in the water. And so you can identify some of these potential biomechanical faults. And so we utilize this, burn a CD for them so they can go home and kind of watch it. You can do it again later if need be to kind of compare. And really education. And not only for the swimmer, coaches, parents, everybody involved along the line here. It's going to be important from an education standpoint. What's going on? What do we need to do to try to fix this? It's very much a team approach. I only have a small amount of time with these athletes, They go home, depending on the age of the athletes. There may be a parent involved. If it's college level and they're off to college, there may not be a parent involved. Hopefully there's a trainer at least. But so there may be a lot of parental and then coaching involvement, obviously. These next few slides, by no means an exhaustive list. These are just some things that I kind of pulled out from exercise suggestions. Feel free, this is an ongoing process. I kind of have a swimmer shoulder packet. I know Tom has it, but feel free to email me sometime, and I'll give you my email here at the end because I naturally forgot to bring some cards. But I have kind of a packet of things I put together for some of the athletes. Not every athlete needs everything on there. There's some things that are definitely kind of staged. But with a lot of the athletes, I try to work on developing kind of a posterior dominant shoulder. Again, they're plenty strong pulling through in front usually. Where they lack oftentimes is in back and on top, that supraspinatus tendon. So we try to develop a dominant shoulder in back, really work the back side. And so that we may do just basic single arm external rotation, especially if they're really early symptomatic. Keep them down low, they're not going to get into a position of impingement. As long as the resistance is light enough, generally they do all right. And so with this, again, we're talking kind of a light to moderate repetition, high volume work here. So I may start them out on 3 to 10 if they're symptomatic, but ultimately, 3 to 20 or more of that. Kind of this double arm external rotation is another one I utilize. The nice thing about that, we're working both sides at the same time, and there's been some nice studies that have shown real high activation of kind of that low trap area for people who are lacking, which is probably quite a few. Low trap, lower trapezius, like I said, it really helps with controlling that shoulder blade position. But in a lot of, one of the great ways to work it is to lay somebody down and have them do this Y exercise. But if you have somebody who's in an early stage, there's no way they're going to tolerate that. And so a lot of times we can get them into this and start to work low trap down here. Prone T's and Y's, getting them on an unstable surface on the ball, working on basically just rhomboid mid trap strength, low trap strength here, and again, like I said, low trap here. This is also another nice one, thumb up for hitting that supraspinatus tendon, depending on how symptomatic they are. I'll start them out, oftentimes no weight at all, high rep again, depending on how symptomatic they are, and then gradually advance. Generally, this one on the Y's, again, you're talking a long lever arm. And so it's torquing quite a bit on the shoulder. For most of our swimmers, I'm not going much above 2, maybe 3 pounds, and just high volume. They don't have to exert any force upward in this position. And so there's no point in hammering a heavy weight there.
What's the move, just to stay there?
Oh, what's that?
What's the move?
So they're down in here. If they're on the ball, they're literally coming from here on up. So they're just going into this Y position versus this T position. So the T position, one of the things that I recommend watching for with some of the swimmers, a lot of times, again, these are lax athletes. They're inherently loose. So they will kind of come in here and they'll just lever their ball and socket. But you watch the shoulder blades, they don't retract much at all. Or if they do, it's just not adequate. And so they'll just kind of fly in through here and they're just kind of levering back and forth at the ball and socket. I don't need their arm to be way behind them. That's why we got rid of the buddy stretches that they did back in my day a long time ago, because it just demolishes the front part of the shoulder. I just want them to come back enough that they get a good squeeze without having to overstretch the front part of the shoulder capsule. All right, so some additional things. Again, like I said, not necessarily an exhaustive list, but basic rows. What's called a 4-stage row. There are too many pictures to throw on the slide, but a 4-stage row is something where you can work unilaterally. So you have your swimmer, they have a band out in front of them, they start more or less from a little bit of a protractor position, they're a little bit forward, and they initiate it with shoulder retraction. Because a lot of times people have no problem pulling the arm back, but what they have a hard time doing is really isolating shoulder blade muscles coming back. So a 4-stage row has them retract first, then draw back, then let go, and then relax. So we're breaking it down into components. And again, you can use it, you basically just do it unilaterally and have them work on their ability to retract, especially for our butterfly and freestylers. And so as you come in through here, you've got to be able to retract initially to have good clearance as you're coming around. low and mid rows, so you can just do basic rows in here. If they're not highly symptomatic, I'll bring them out a little bit and work on it in here as well. But if you have somebody who's really symptomatic, the more you elevate them in here, if they have a real swollen tendon burst or that sort of thing, you can kind of be raking that back and forth against the underside of that overlying bony and ligamentous arch. Lat stretching, I kind of talked about that a little bit earlier. Pectoral stretching. With the pec stretching, you really have to kind of watch that. In the symptomatic ones, it may be, I may just have to start them really low. So I'll even put them in here in the doorway and have them work on retracting back, because they may be way too symptomatic to even get up here. And so you may start them low, and then you can bring them in here and open up, but you really want to look for a couple things. They can't lean on it, which is what a lot of them do. If you lean on it, now you're holding yourself up with your pec, and you're really loading it quite a bit more than you need to. Ideally, their weight is on their feet, so if the wall fell down or the doorway or whatever they're doing, they're perfectly balanced, no problem. Their weight's on their feet, they're just rotating away, not to completely overstretch the front part of the shoulder, just to get a pec stretch. That's all you're looking for. And then if they are symptomatic, eventually I'd like to get their elbow just a little bit above shoulder height, because your pec has fibers that run at different angles. And if you can kind of get them elbow a little bit above shoulder height, you can kind of catch a little bit more of that. Serratus anterior strengthening, this is a biggie. Like I said, this and that subscapularis are the two muscles that fire continuously throughout the stroke cycle. So again, heavily prone to fatigue. Depending on the level of their symptoms, you may start them on just basic punches. So here, all they're doing, the movement, all it is, they're on their back, and they can do it on a bed or a table or on the floor. But all it is, arms are here, and literally it's just a punch. And then they relax. And so again, that muscle comes around and attaches to the ribs. All it's doing is contracting and pulling the shoulder blade forward, and then relaxing. That's it. There are a multitude of ways to work this. This is generally the easiest way to start. Even the symptomatic ones I'll throw on a ball. You kind of find nowadays a lot of things are really getting more towards performing some of these exercises on an unstable base, because they just find you're getting some core activation here. I'm getting glutes, I'm getting low back, so I'm having to stabilize my midsection as I do it. And so you can start out here. Generally, they'll do fairly well, even if they're symptomatic. And I may just put 2-3 pounders in their hands. If they're real symptomatic, it's just the weight of the arm. They can do what's called a dynamic hug, a little bit more advanced. So you have your band behind you, and literally what they're doing is they're just coming around and then back. And so it's kind of like you're hugging around a large tree or some object, and they're just getting those shoulder blades pulled flat against their back and down and around. I'll do kind of a wall alphabet in here, and I need to get you an updated copy, Tom, of that, because I've changed it a little bit. What they're doing in this case is they're loading on their arm, but they're holding themselves in this protracted position. As they do that, now they're just doing capital letters, A through M, A through Z, whatever they can handle. But you have to watch in this case, because a lot of times then they'll just start to flip off their back eventually. They lose that contraction. And this is kind of one of those proprioceptive exercises that we talked about earlier. So from there, you can get into, I know like the whole wheelbarrow idea back, for dryland training, you do wheelbarrows, you do ball walkouts off of a ball, if anybody's ever done those. I mean, those are all great ways to work on serratus anterior strengthening. Push-ups. I mean, there's real high activity of this muscle with just even a basic push-up. So, and what we'll try to do sometimes is not necessarily get them toes and hands, but even do, toes or hands and knees, and push up with that little bit of a plus maneuver to try to really get that serratus to kick in. Inter-rotation strengthening we'll do for some. I mean, I guess anecdotally, not a lot of the athletes that I see are really lacking a lot. They're in that, unless they have, if we're talking about like that tendonitis problem, they're usually plenty strong with that. But because it is one that is, firing all the time and prone to fatigue, we may work inter-rotation strengthening up in here, or you can throw them, on their stomach, get the arm positioned with a little bit of a towel to just keep that arm kind of lined up in the plane of the body, and then just very limited inter-rotation in this position. So, and just repetitious. And so, And the other thing, if you're heading to the pool, don't forget the things you need. This is my daughter. I don't know why. She's always a good idea, but her Jamaica suit, her ladybug antennae, and her little recorder. So, and again, I wanted to thank Dr. Hutton, and then also Dr. Scott Reynolds is one of the other sports medicine physicians here who provided some of the images that I used. So I kind of want to just really open it up, questions for myself, Dr. Hutton, dialogue. Like I said, I would like to make it fairly informal. Or if there's anything that you wanted to add, or thoughts, comments, criticisms.
Well, with limited, I wouldn't say limited time, but, there's so much training and other stuff we need to get in. Like, how do we prioritize some of these exercises, or, is there any kind of hierarchy you would say, or?
Well, a lot of it's, really identifying the impairments first. So, if you have an athlete that you're working with having shoulder pain, then yeah, it's an issue finding out in terms of picking them. Okay, what do they really need to work on? What's the problem? I mean, are they tight in front? Chances are they probably are. But again, if you really had to choose, again, my emphasis is in that posterior dominant shoulder. So your external rotation work, your mid-back work. In any of those, there's overlap between them, as you can probably imagine. It's just positionally things. One position may recruit one muscle a little bit more than another. But yeah, so you'd be focusing fairly heavily on the back portion, both rotator cuff and shoulder blade would probably be the thing that I would
And
really.
then even with like prevention too.
Yeah, from a preventative standpoint. Ideally, we would like to maintain, in a perfect world, a normal balance between strength and front. I mean, it's never going to be equal, but you just need to maintain adequate strength in back, again, for most of our swimmers to be able to get through, whether it's practice or it's a mile or whatever the case may be, to be able to get through and be able to maintain by, if it's their mile and they're flipping at their 800 or the 900 portion, that they're still getting around all right. They're not getting lazy in the shoulder blade, and now they're still trying to get the same amount of recovery range of motion, but getting it now more from the ball socket. So yeah, there would be a lot of back work from a preventative standpoint, back part of the cuff. Yeah.
Would there be an advantage on, or any better part in the season to be doing stuff like this? Would you see any huge advantage to having this kind of training at the end when we're resting and we're doing less yardage?
If it's something that hasn't been really done during the program, I don't know that I'd want to introduce a whole new training element, especially if they're getting ready to start taper, that sort of thing. I wouldn't do it there. Ironically, where a lot of the athletes need it the most is during their downtime, unfortunately. So, they finish up long course season and they sit on their rears, maybe as I did, for, a month or more, depending on how far into the season they go. And then they don't do anything, and then they jump back in the water. And again, that was one of the problems. And so, and it doesn't take a lot. I mean, with a lot of these exercises, you can get through some of these in 15, 20 minutes, and even if they just do that 3 times a week, that would be it. I mean, they don't need a lot of them, and generally you could probably argue that we are all more compliant if we don't have 25 things to do. If you pick maybe, 4 or 5 things, that'd be better. But from a season standpoint, the off season would be important, and then really more in kind of the early to mid. You're still doing a fair amount of yardage. You're still maybe doing some dry land, incorporating that into the training. A lot of this, I just think it'd be helpful to just incorporate into a dry land routine. They don't all have to be done, but just pick some of the key ones. Again, there is some overlap, and you can pick some. It can be an equipment issue, space issue, whatever the case may be, and kind of customize it to what you need. But yeah, off season, early and mid. Long answer to your short question. That would probably be my biggest recommendations. Yeah.
Would you not recommend doing these exercises before swim practice? Would you see it? Could you
The concern is that if they're doing them and they're doing high volume, again, they're doing, ideally, some burnout sets. And so then to do that and hop in could potentially be problematic. And it's kind of like from a therapy standpoint, whether it's an ACL or whatnot, you're going to save a lot of your endurance stuff for the end. A lot of your skilled stuff you're going to do first, so mechanically they're all right and you're safe doing it. But then your more endurance-based stuff, whether it's not real technical, you throw that at the end. Yeah, in a perfect world, and I realize it's probably not always the easiest, whether it's from, you know, time pool, you know, availability of pool time, things like that. But ideally, you'd like to do it at the end, you know, where they can go ahead and do 3 sets of 20, 25 of a given exercise, do some burnout sets, and then they're done. And they can take off, they're done for the night. You know, again, they'd only ideally be doing this, you know, maybe 3 days a week or so. Anything else? All right, well, my email, if any of you guys have questions, is tom.niemann, Niemann, @nohmail.com. And so if you have questions you think of later on, or, you know, down the road as the season progresses, things like that, please don't hesitate to get in touch with me, and be happy to help you as much as I can.